5 hepatitis viruses. 2 arrive by the fecal-oral route and never become chronic. 3 arrive in blood and body fluids, and 3 of those can persist for life. That single split organizes almost everything else. Today we take each virus in turn. We will spend the most time on hepatitis B serology, because it is the thing residents get wrong most often, and the thing you will be asked about most. And we will finish with the modern hepatitis C regimens that cure well over 90% of patients. Let's begin. Start with the epidemiology, because it is not what most people guess. In the United States, hepatitis C accounts for roughly 79% of acute viral hepatitis, hepatitis B about 16%, and hepatitis A about 5%. Worldwide, the picture is different. Hepatitis E is the most common cause of acute viral hepatitis in endemic areas. So the virus you should think of first genuinely depends on where your patient has been. Here is the plan. First, a map of all 5 viruses. Then hepatitis A. Then hepatitis B in depth, including the full serologic panel and the phases of chronic infection. Then hepatitis C, from transmission through to cure, with direct-acting antivirals. Then hepatitis D, which cannot exist without hepatitis B. And finally hepatitis E, and the reason it is so dangerous in pregnancy. Along the way, we will stop twice to interpret real serologic panels. Here is the orienting table. Hepatitis A is a single-stranded RNA virus spread fecal-orally, and it never becomes chronic. Hepatitis B is a double-stranded DNA virus spread by blood, sexually, and perinatally, and it can become chronic. Hepatitis C is single-stranded RNA spread mostly by blood, and it becomes chronic in up to 85%. Hepatitis D is RNA, and it requires hepatitis B to exist. Hepatitis E is single-stranded RNA spread fecal-orally, and it only becomes chronic in transplant patients. Vaccines exist for A and B. We start with hepatitis A, the virus that gives you a miserable few weeks and then leaves for good. Hepatitis A spreads by the fecal-oral route, contaminated food and water. Shellfish, daycare centers where nappy changing and hand hygiene collide. And international travel. The incubation period is 2 to 6 weeks. And here is the crucial fact. There is no chronic carrier state for hepatitis A. None. Once the antibody forms, immunity is lifelong. So a patient who has had hepatitis A cannot get it again and cannot transmit it years later. Clinically, it looks like most acute hepatitis: reduced appetite, malaise, fever, nausea, and vomiting, right upper quadrant pain, and jaundice. Acute liver failure is rare, but the risk is higher in someone who already has chronic hepatitis C. Diagnosis is simple. Acute infection means a positive immunoglobulin M anti-hepatitis A antibody. Past exposure means a positive immunoglobulin G with a negative immunoglobulin M. Immunoglobulin M means now. Immunoglobulin G alone means before. That rule will serve you across all of viral serology. Treatment of acute hepatitis A is supportive. There is no specific antiviral therapy. The one thing that changes management is acute liver failure, and that means immediate referral to a liver transplant center. Vaccination is the real intervention. Vaccinate men who have sex with men, people who inject drugs, anyone with chronic liver disease of any cause, and international travelers to endemic areas. It is a 2-dose series. Note that chronic liver disease group. They are vaccinated because superimposed hepatitis A on a damaged liver is dangerous. Now hepatitis B, the virus with the serology panel everyone struggles with. We are going to build that panel one marker at a time so that by the end, you can read any combination. Hepatitis B travels 3 ways: in blood, which historically meant transfusion and now largely means injection drug use; sexually, and perinatally from mother to infant. That third route matters more than the others for what happens next. The incubation period is long, 6 weeks to 6 months, with a mean of 12 to 14 weeks. And that long incubation is exactly why patients often cannot recall an exposure. By the time they are jaundiced, the event is 3 months behind them. Acute hepatitis B is silent in about 70% of people. They never know they had it. About 30% develop jaundice and feel genuinely unwell, and under 1% develop acute liver failure. But that small group carries a mortality of up to 60%. So the distribution is heavily skewed. Most patients have nothing, and the few who decompensate do so catastrophically. That is why altered mental status or a rising international normalized ratio in acute hepatitis B is an admission. This is the number to carry out of the hepatitis B section. Fewer than 5% of adults who acquire hepatitis B go on to chronic infection. More than 90% of infants infected perinatally do. An immature immune system does not clear the virus. It tolerates it. That single fact explains global epidemiology. It explains why perinatal prophylaxis matters so much. And chronic infection is defined simply: Hepatitis B surface antigen still positive after 6 months. Immunosuppression raises the adult number. About 40% of chronic hepatitis B eventually progresses to cirrhosis. And 4 things make that worse: Hepatitis C co-infection, Hepatitis D co-infection, human immunodeficiency virus co-infection, and alcohol. Notice the shape of that list. 3 of the 4 are other blood-borne infections that share the same routes of transmission. So when you find Hepatitis B, look for the others. A patient with 2 of these is on a materially faster track to cirrhosis than a patient with 1. Hepatitis B causes hepatocellular carcinoma even without cirrhosis, so screening criteria are broader than you might expect. Screen anyone with cirrhosis, anyone with a family history of hepatocellular carcinoma, then by ancestry and age. People of African ancestry over 20, Asian men over 40, Asian women over 50, and anyone over 40 with a raised alanine aminotransferase, with or without a hepatitis B DNA above 2000. Screening is alpha-fetoprotein plus ultrasound every 6 months. Hepatitis B has extrahepatic manifestations worth knowing. Polyarteritis nodosa is the classic association. It occurs in under 1% of patients, but the link is strong enough that polyarteritis nodosa should prompt hepatitis B testing. Membranous nephropathy, membranoproliferative glomerulonephritis, and arthritis. The practical point runs in reverse. When you meet these conditions without an obvious cause, send hepatitis B serology. Build the panel in 2 halves. First, the antigens and the viral DNA. Hepatitis B surface antigen appears before symptoms, and it is what we screen blood donors with. If it is still positive beyond 6 months, the infection is chronic. Hepatitis B E antigen is evidence of active viral replication, and it marks increased infectivity. Remember that pre-core mutants do not make it. And hepatitis B DNA in the serum correlates with active replication inside the liver. That is your quantitative measure of how active the infection is. Now the antibodies. Immunoglobulin M anticore is the first antibody to appear, and it indicates acute infection. Hold on to it, because it is the only clue during the window period. Immunoglobulin G anticore means previous infection if the surface antigen is negative, or ongoing infection if the surface antigen is positive. And crucially, it never appears from vaccination. Anti-surface antibody means resolution and immunity, and it is the sole marker after vaccination. Anti-E antibody means waning replication and decreased infectivity. Here is the whole panel. Acute hepatitis is surface antigen positive with immunoglobulin M anticore. The window period is the tricky one. Surface antigen has gone, and anti-surface has not yet arrived, so immunoglobulin M anticore is your only positive marker. Resolved infection is anti-surface positive with immunoglobulin G anticore. Immunization is anti-surface positive with nothing else, and the 2 chronic states differ by E antigen. Note the pre-core mutant footnote. It makes no E antigen but develops anti-E, and it is associated with a raised viral load. Pause and work this one out. A 34-year-old born in East Asia is being screened before starting rituximab. The surface antigen is negative. The anti-surface antibody is negative, but the immunoglobulin G anticore antibody is positive. Alanine aminotransferase is normal, and the viral DNA is undetectable. Now think, anticore never comes from vaccination, so this person has genuinely been infected at some point. But there is no protective anti-surface antibody. What is this, and does it matter before rituximab? Here is the answer. A positive anticore antibody with a negative surface antigen means past infection. An anticore never comes from vaccination, so this is real prior exposure. The virus has not been eradicated from the hepatocyte. It persists as covalently closed circular DNA. Rituximab is one of the highest risk drugs for reactivation, and reactivation here can be fatal. So the source specifically says to screen before chemotherapy, anti-tumor necrosis factor agents, rituximab, and prolonged high-dose steroids. And treat prophylactically. Chronic hepatitis B is not 1 state. It is 5. The immune-tolerant phase has a normal alanine aminotransferase with an enormous viral load and minimal histological damage. Cirrhosis risk is under 0.5% per year. The immune-active phase has a raised alanine aminotransferase and moderate to severe inflammation, 2 to 5.5% per year. The inactive carrier has a low viral load and almost no inflammation, 0.05%. And E-antigen-negative hepatitis is the most dangerous phase at 8 to 10% per year. 6 indications for antiviral therapy. The immune-active phase, hepatitis B, E, antigen-negative chronic hepatitis B. Cirrhosis, with a viral load at or above 2,000. Decompensated cirrhosis, due to hepatitis B. Acute liver failure from acute hepatitis B. And the special populations. Third trimester pregnancy with a viral load above 200,000 to prevent vertical transmission. Inactive carriers about to receive immunosuppression. Hepatocellular carcinoma. And hepatitis C co-infection. Notice the immune-tolerant phase is not on this list. 3 first-line agents. Entecavir and the 2 tenofovir formulations. All are well tolerated with low resistance. At 5 years, hepatitis B antigen seroconversion occurs in 30 to 40% and loss of surface antigen in 5 to 10%. So these drugs suppress far more often than they cure. Tenofovir is preferred if there is a history of lamivudine resistance, and there is no known tenofovir resistance to date. The disoproxil formulation carries a small risk of bone loss and kidney dysfunction. Alafenamide is gentler on both. Duration and special situations, briefly. For antigen-positive immune-active disease without cirrhosis, if seroconversion occurs, you may stop after a year, provided the alanine aminotransferase is normal and the DNA suppressed, or continue until surface antigen clears. For e-antigen negative reactivation, treatment is indefinite. With cirrhosis, indefinite. After liver transplant, hepatitis B immune globulin plus a nucleoside analog. In human immunodeficiency virus co-infection, use 2 agents active against both. And after exposure, immune globulin followed by vaccine. Now hepatitis C, the virus that used to mean decades of slow fibrosis, and now means 8 to 12 weeks of tablets and a cure. Hepatitis C is predominantly blood-borne. Injection drug use is the dominant modern route, and transfusion before 1992 accounts for a historical cohort. Sexual transmission occurs, but it is far less efficient than for hepatitis B. And in 20 to 30% of patients, no clear precipitant is ever identified. So a negative risk factor history does not exclude it. The incubation period is 1 to 5 months, with a mean of 6 to 7 weeks. And current guidance is to screen all adults at least once. 80% of acute hepatitis C is subclinical. 10 to 20% develop a symptomatic hepatitis with jaundice. Acute liver failure is rare, and up to 85% go on to chronic infection. That is the inverse of hepatitis B in adults, where under 5% become chronic. Whether a person clears the virus spontaneously is partly genetic. It is associated with the interleukin-28B genotype and with human leukocyte antigen class II genotypes. Chronic hepatitis C is slow. 20 to 30% develop cirrhosis, and it typically takes about 20 years. The risk is higher in men, higher with alcohol, higher with human immunodeficiency virus co-infection, and higher in smokers. Once cirrhosis is established, hepatocellular carcinoma develops in 1 to 4% of patients per year. And note that cancer risk persists after cure, so a cured cirrhotic patient still needs surveillance. Hepatitis C has more extrahepatic disease than any of the others. The immune complex group. Mixed Cryoglobulinaemia is the classic one, with leukocytoclastic vasculitis and membranoproliferative glomerulonephritis. The dermatologic group. Porphyria cutanea tarda and lichen planus. The hematologic group, non-Hodgkin lymphoma and monoclonal gammopathies, and then thyroiditis and idiopathic pulmonary fibrosis. Any of these should make you check a hepatitis C antibody. This distinction is the single most useful thing in hepatitis C testing. The antibody becomes positive at about 6 weeks, and it does not mean recovery, and it does not mean immunity. It can even become negative years after recovery. The RNA becomes positive within 2 weeks, and it is the marker of active infection. The RNA is what decides whether someone needs treatment, and the genotype, 1 through 6, guides duration. Genotype 3 is associated with a higher risk of hepatocellular carcinoma. 3 states and 2 tests. Acute infection means the RNA is positive, and the antibody may or may not have appeared yet. Resolved infection means the RNA is negative, with the antibody either present or, over time, gone. Chronic infection means both the RNA and the antibody are positive. So the RNA does all the work. The antibody only tells you the immune system has met this virus at some point in the past. If you remember one thing about hepatitis C testing, remember that. 2 first-line regimens, and both are pangenotypic. Sofosbuvir-velpatasvir for genotypes 1 through 6 over 12 weeks. And glecaprevir-pibrentasvir for genotypes 1 through 6 over 8 weeks. Learn the suffixes because they tell you the class. A drug ending in buvir is an RNA polymerase inhibitor. A drug ending in asvir is an NS5A inhibitor. And a drug ending in previr is an NS34A protease inhibitor. Every modern regimen is a combination of 2 of those classes. Not everyone needs a specialist. The simplified pathway covers adults with hepatitis C who have no cirrhosis or compensated cirrhosis and who have never been treated before. Those patients can be treated and monitored in primary or general medical care. 6 groups leave that pathway. Human immunodeficiency virus co-infection, hepatitis B surface antigen positive, pregnancy, hepatocellular carcinoma, end-stage renal disease or liver transplant, and anyone decompensated or previously treated. Those go to gastroenterology. Who to treat? For chronic infection, treatment reduces hepatocellular carcinoma and mortality, and it is recommended for everyone except those with a limited life expectancy from another cause. For acute infection, wait to see if it clears. If it has not cleared by 12 to 16 weeks, treat with the same regimens. Vaccinate every chronic hepatitis C patient against hepatitis A and hepatitis B if they are not already immune. And note that needle stick risk is about 3%, and there is no recommended post-exposure prophylaxis. Monitoring in 3 parts. Before starting, check a full blood count, international normalized ratio, liver tests, glomerular filtration rate, and viral load. And remember, protease inhibitors are contraindicated in decompensated liver disease, or a Child-Pugh score of 7 or above. Stop treatment if jaundice develops. If there is nausea, vomiting, or weakness, a 10-fold rise in alanine aminotransferase, or a significant rise in bilirubin, alkaline phosphatase, or clotting after 4 weeks. And the endpoint is sustained virologic response. No detectable virus 12 weeks after finishing. That is a cure. 2 viruses left. One that cannot survive without hepatitis B, and one that is usually trivial, except in one group where it kills. Hepatitis D generally requires hepatitis B to cause infection because it borrows the hepatitis B surface antigen as its envelope, and the timing changes the outcome completely. Co-infection, where both viruses arrive together, resolves in more than 80% of cases. Superinfection, where hepatitis D lands on established chronic hepatitis B, leads to chronic dual infection in most cases, with accelerated progression to cirrhosis and increased cancer risk. In rare cases after liver transplant, it can replicate autonomously. Hepatitis D spreads by blood or sexual contact, and it is endemic in Africa and Eastern Europe. The testing rule is simple, and it is worth adopting. Check a total anti-hepatitis D antibody once in every patient with hepatitis B, not just the ones with risk factors. If that antibody is positive, confirm with hepatitis D RNA. Finding hepatitis D changes both prognosis and management, and the only way to find it reliably is to look in everyone with hepatitis B. Hepatitis E is the most common cause of acute viral hepatitis in endemic areas worldwide. It spreads fecal-orally. Think of travelers to Central and Southeast Asia, Africa, and Mexico. In Europe, cases are associated with swine exposure through undercooked pork. And here is a surprising statistic. There are few recognized cases in the United States, yet about 16% of the population carries immunoglobulin G anti-hepatitis E, so exposure is far more common than diagnosis. Hepatitis E is often asymptomatic, but in pregnancy mortality from acute hepatitis E runs 10 to 20%. That single fact is why the virus matters clinically. It can also rarely become chronic, but only in transplant patients on immunosuppression. Diagnosis is by immunoglobulin M anti-hepatitis E, which in the United States is sent through the Centers for Disease Control, or by hepatitis E RNA. Treatment is generally supportive, and be aware of extrahepatic features. Arthritis, pancreatitis, anemia, and neurological disease including Guillain-Barré syndrome. Last case. A 28-year-old woman 30 weeks pregnant returned from rural South Asia 4 weeks ago. She has nausea, malaise, and now jaundice. Her alanine aminotransferase is 1100, bilirubin 6.2, mostly direct, and her international normalized ratio is 1.6 and rising. The hepatitis A immunoglobulin M is negative, the hepatitis B surface antigen is negative, and the hepatitis C RNA is negative. So which virus is this? And why should that rising clotting time frighten you? This is hepatitis E. Travel to an endemic area with a 4-week incubation fits. And hepatitis A, B, and C have all been excluded. Confirm with immunoglobulin M anti-hepatitis E, or hepatitis E RNA. The rising international normalized ratio is the frightening part, because it means synthetic function is failing. That is acute liver failure territory. And in pregnancy mortality runs 10 to 20%. So she is admitted. Obstetrics and hepatology are involved. And she is transferred to a transplant center, while she is still well enough to travel. The pitfalls. A positive hepatitis C antibody is not immunity and not recovery. Do not miss the window period where immunoglobulin M anticore is the only positive marker. Remember, anti-core never comes from vaccination, so it always means real infection. Screen for Hepatitis B before rituximab, anti-tumor necrosis factor agents, or prolonged steroids. Do not treat immune-tolerant Hepatitis B. Check Hepatitis D once in every Hepatitis B patient. And think of Hepatitis E in a pregnant returning traveler. 6 things to carry with you. 1. A and E come fecal-oral and never become chronic in immunocompetent people. B, C, and D come in blood and can. 2. Age at acquisition decides Hepatitis B chronicity. Under 5% in adults, over 90% perinatally. 3. Immunoglobulin anti-core defines the window period, and anti-core alone never comes from a vaccine. 4. Hepatitis C antibody means exposure. Only the RNA means infection. 5. Modern antivirals cure over 90%. 6. Hepatitis E in pregnancy is lethal. And other viruses, including pegivirus, cytomegalovirus, Epstein-Barr, herpes simplex, and varicella, can all cause hepatitis 2. These are the sources behind today's teaching. The American Association for the Study of Liver Diseases Guidance on Chronic Hepatitis B. The Joint Hepatitis C Guidance maintained at hcvguidelines.org. The Hepatology Guidance Update on Hepatitis C. The Centers for Disease Control Surveillance and Vaccination Recommendations. And the reviews of Hepatitis E virus infection. Thank you for watching. Verify everything here against your own institutional protocols before applying it at the bedside.